Wounds.
Good morning. Can you hear me okay? No? Little higher. Okay. Is this better? Better? Can you hear me now? Better? So, I think our clock here is a little bit slow. What time do you have? Okay, I need somebody to volunteer to be my timekeeper, and your job would be at 10 till the hour, you would raise your hand and say it's time for a break. Can I have a timekeeper, please? Thank you. All right. Well, good morning. Happy Monday morning. I get to see your faces on a Monday morning first thing instead of Friday late afternoon. So there's an attendance sheet that's going around. Make sure you sign that. Try to turn off. Is that better? Is that better? All right. So at 9 o'clock on Monday morning, we are going to talk about wound care management. Okay? Some of this information will be a recap from fundamentals. We've had some wound care and fundamentals. So we're going to touch on some of that, and then hopefully you'll learn something new today. All right, so to begin with, we're going to talk about the layers of the skin. And we know that the integumentary system is our primary defense against pathogen invasion, right? So there's several layers of the skin, and each of them have a role to play in keeping us healthy. And there has been a new finding, I don't know if you have been aware of this, but there's a new finding of an additional layer of skin called the interstitium layer. And researchers accidentally found it, they accidentally discovered it when they were looking at living tissue. Because what happens is when tissue is prepared to be evaluated by the microscope, the fluids are drawn away from the tissue. So they don't see these tissues when they're looking at microscopic samples because they've taken the fluid away. So if that is an accidental discovery, and I'm just bringing that to your attention, that nursing and science is ever evolving, there's always new discoveries. So that's something new and interesting to be made aware of. So anyhow, so with the layer of the skin, we know that they are used to help prevent pathogen invasion, and we know that when there is a break in the skin, that allows a portal of entry for bacteria to come in. So the epidermal layer, we know that, and this is just a recap of AOP, and just go with me. You don't have to really take a bunch of notes on this. Just kind of refresh yourself on this. So the epidermal layer that keeps the fluids in, pathogens out. The dermis, or the dermal layer, helps for collagen rebuilding. Remember all the fibrin and collagen, the structural changes. So when injury occurs, and it can be an accidental injury or it can be an intentional injury, such as a surgical incision. When that occurs, what do you expect to see as a result of that? What will happen in the body? There'll be an increased blood flow to the area, which results in what? Anybody know? Swelling. What else? Inflammation. So since Andy said inflammation, we'll go to our next slide. It actually activates the inflammatory response because of that increased blood flow in the area. And again, that can occur as a result of an accidental injury, or it can occur with an intentional injury, such as a surgical incision. So the signs of inflammation are more of a localized response. So you'll see heat and redness and swelling and pain because the nerve endings are irritated by the pressure and the chemical stimulants that are being released. And you'll also see loss of function because it just, quite frankly, hurts to move, all right? So those are your inflammatory responses. A systemic response that you might observe would be an increase in white blood cell count, and you might also see a fever because the body's trying to respond to the pathogens that have been introduced. They've stimulated the immune system. So we're going to talk about wound classification today. So as an example, something that you can relate to, we classify things all the time, sometimes not even being aware of it. Some of the ways that we classify, or if you were going to organize your closet, you might sort your clothes by color or by season, by size, by trends, fashion. There's several ways to classify something. You might put them together as individual pieces or even outfits. And the same is true with wound classification. There's three main things that we look at. We look at the etiology, or what caused it, what happened to allow the wound to occur, the depth, how deep the wound is, and the color of the wound. And the color is going to speak to us about the severity of tissue impairment. So speaking of the etiology, we have two main categories, so surgical and non-surgical. And within those categories, we can further classify this wound as acute versus chronic in both areas. So on the surgical side, an example of an acute wound would be a closed incision or an excision with an open excision. So something that was intentionally done to the patient as far as a surgical procedure, whether it be closed or open, and then skin grafts, and then those donor sites that the skin grafts came from. So those would be examples of an acute surgical wound. A chronic surgical wound would be a dehisced wound or a wound that's been infected, and we'll get into that a little deeper as we go through today. So that would be an example of a chronic surgical wound. Non-surgical wounds, acute would be skin tears, burns, abrasions, or trauma. Something that happens suddenly, unexpected, and that would be non-surgical. Chronic would be those wounds that don't heal easily, so maybe pressure ulcers or leg ulcers or foot ulcers that take a long time to heal. Those would be considered a chronic wound. Okay, so with acute wounds, what happens, bleeding occurs, and that stimulates clot formation. And that also initiates the wound healing cascade. And the wound healing cascade can be categorized into three main phases. And I put two examples on each line because sometimes it's referred to as defensive or inflammatory, and they're one and the same. So that goes for each line. So defensive or inflammatory, proliferative or reconstructive phase, and then the remodeling and maturation phase. And we're going to dive into these a little deeper. So this slide, I'm going to give you a lot of information, but don't worry. This morning, I posted everything I'm going to say. I put it in a Word document, and it's on Canvas for you. Okay? So I'm going to go through this. Some of you aren't going to grasp it the first time around. It's okay. I have that Word document right there for you. And this is all AMP, a refresher type thing. Okay, so I just want you to understand what's going on in the body when a wound or injury occurs. Okay? So the first phase is going to be that defensive or inflammatory phase. This occurs from the initial insult, so when it first happens, up to 3 to 6 days post happening. Don't get hung up on the days, all right? This is just refresher, okay? Two major processes occur during this phase, and that is hemostasis, or the cessation of bleeding, and phagocytosis. That's when the microorganisms are captured by the macrophages. Remember those blood cells that go in and help clean up the debris. Initial vasoconstriction of the arterioles occur. Histamine is released by cells, which causes that inflammatory response. And because of that inflammatory response, with that vasodilation and increased blood flow at surgical site or the site of injury. So everything's rushing to that site. They need help, right? They call the code, so to speak. Tough crowd. White blood cells, neutrophils, macrophages, they're all drawn into that site, right? Because they're there to help. The macrophages will then secrete angiogenesis factor. That's the factor that stimulates the formation of those epithelial buds, or that new granulation tissue. They actually create a microcirculatory network, right, to try to rebuild that wound or that site of injury. Tissue injury initiates the mobilization of phagocytes into the wound before bacterial contamination occurs, right? So the body's already prepping that there's going to be some bacteria coming down the line, so let's get there, let's get ready, all right? That's what's happening. Deposit of fibrin or connective tissue and blood clot formation provide the matrix for cell repair within the wound. Then a scab forms on the wound, right? We have a scab. That aids in hemostasis, so with blood control, and inhibits contamination from other microorganisms. If you have a scab in place, you need to leave it alone because the fluid underneath that scab is actually bathing that new wound. And also, it's a Band-Aid. It's nature's Band-Aid, so you want to leave it alone. The increased blood flow brings oxygen and nutrients to aid in healing. This is a big advantage against infection. By 24 hours, the monocytes enter the site, and monocytes, if you remember, are the largest white blood cells that fight infection. They ingest and break down microorganisms. When the monocytes show up, one of two things happen. Either there's minimal contamination and collagen starts to displace fibrin to begin further wound healing, or that's what we want to happen, or there's a proliferation of microbes. There's some type of organism in there, and then the bed is filled with necrotic tissue, neutrophils, and bacteria that constitute pus. So this is the stage where whether it either does one of two things with the monocytes. That either everything's minimally contaminated, or there's problems there and they begin to develop because the monocytes become pro-inflammatory instead of anti. And it all has to do with what's in the wound, okay? So the inflammatory response is essential for healing. We have to have the inflammatory response to heal properly. So things that impair inflammation, such as the use of steroid medication, they can put this healing process at risk, right? We need that inflammatory response. Then the proliferative phase, that occurs between day 3 and day 21. That's when the replacement of fibrin with collagen continues. It's strengthening the wound. Capillaries are growing across that wound and increasing blood supply. Fibroblasts, they move in from the bloodstream into the wound, and they are depositing fibrin, and then that capillary network develops. So it's translucent red in color. The wound would be translucent red in color. And again, that's granulation tissue. It's very vascularized, so it bleeds extremely easy. If you're doing a wound change, dressing change on a wound, and there's granulation tissue in the wound bed, if you touch it, it's going to just bleed because it's very vascularized. When the granulation tissue matures, epithelial tissues will then, or cells will then migrate to that area, and that's when scar formation begins. All right? So then the last phase is that remodeling maturation phase. That usually occurs on day 21, and it can last 1 to 2 years beyond the injury. Right? It's a process. Fibroblasts continue to synthesize collagen. Collagen fibers contract, reorganizing themselves, and the scar strengthens. And then if an abnormal amount of collagen appears, the result can be a hypertrophic scar or a raised scar, or a keloid is what it's called. And these are common in dark-skinned individuals. Right? Have you ever seen one of those? It's just like a little raised wound, and that's what's happening. Yes, ma'am. Oh, you've seen one. Sorry. Okay. All right. Everything I just went over with you is in that document. All right. And again, that's just a refresher of what occurs in the wound healing cascade. Okay. All right. So continuing on with our etiology, chronic wounds lack that clotting component. So because of that, they don't heal fast. They result in slow healing wounds. Because if you remember, with acute wounds, there's a bleeding that occurs, and that's going to stimulate that clot formation that initiates the wound healing cascade that we just discussed. Chronic wounds, because they lack that clotting component, that healing cascade is not activated. All right, so that's why it takes them so long to heal.
Can there still be bleeding with chronic wounds?
There can be, but it is usually as a result of something's disrupted in the wound bed, not from the actual injury. So they will result in slow healing wounds. Continuing to talk about wound classifications, we're going to move to wound depth. So how deep is the wound? How deep does the wound go? And so, depending on what layer of skin is involved, that classifies our wound depth. And so these are talking about surgical site incisions, surgical site incisions. So it can go from the top layer of the skin all the way down to organ space. Okay, so that would be a depth classification of how deep that it goes. So another way that we classify wound depth is in partial thickness and full thickness. So partial thickness is when the shallow wounds occur in the epidermis and the dermal layer. A shallow wound is going to expose nerve endings, right? So what would be symptoms of a partial thickness wound? It's going to expose nerve endings. Pain is going to be a big symptom, right? They're usually superficial, so they're close to the top of the skin. They're red, raw, and painful because of those exposed nerve endings. Rapid healing occurs by regeneration, and usually with partial thickness wounds, there's no scar formation. All right? Full thickness wounds are deep wounds, and they're often involving the epidermis, the dermis, and sometimes they even extend into the subcutaneous tissue, muscle, or bone. So those are full thickness wounds. Fluid collection may cause pressure and pain, and they heal slowly by scar formation. The patient may experience a loss of function, and these wounds heal by initiation of the wound healing cascade. Another component of wound management regarding classification is the color of the wound. So the three colors that we use are red, yellow, and black. I'm so tempted to play a song that's like black and yellow. So with the red wound, usually those are new wounds without evidence of infection. So there's no infection there or that we can observe. Granulation process is occurring, and we want to promote healing by keeping this wound moist, clean, and protected. Right? Those are our red wounds. This is an example of a red wound. The next classification is yellow. Yellow wounds they are in the inflammatory phase, and they usually have moist necrotic tissue. Slaw is an example, and they may have varying amounts of exudate. Though moist slaw will most often be yellow, it can also be brown or tan in color. Remember, exudate is a material such as fluid and dead phagocytic cells that have escaped from the blood vessels during that inflammatory process, and it's deposited in the tissue or on the tissue surfaces. It needs to be removed by cleaning with normal saline. We need to absorb the exudates and keep a clean, moist environment. So if we have exudate in a wound, such as that, that's going to need to be removed so that the wound healing can occur. This is going to impede wound healing. Our next classification color for a wound is black. The black wound is necrotic, and they have black eschar on them. Again, necrotic tissue must be removed for healing to occur. Oftentimes, necrotic tissue is removed by surgical debridement. And if your patient has a wet to dry surgical, wet to dry dressing order on a wound, we need to know if the intended purpose for that is for debridement or not. Sometimes patients will have a dressing change, wet to dry or damp to dry, and it's time to do the next dressing change. And hopefully at this point, you should be looking to see if your patient has dressing change orders, because that's something that we can do in clinical. We can change dressings, right? So you would look in your orders to see if they have that, if you notice there's a wound on your patient. However, sometimes wet to dry dressing changes, we'll go in to change them, and the first thing the nurse wants to do is moisten that gauze that's packed with normal saline, because they don't want it to pool when we take the dressing out. That defeats the whole purpose of a wet to dry dressing change, because a wet to dry dressing change oftentimes is prescribed for debridement. They want the dressing to dry, and then when you go to change it, it pulls out some of that necrotic tissue. So what would be a good nursing intervention to do for your patient before doing the next wet to dry dressing change? That's right. Do a pain assessment and then actually administer the pain medication as ordered. So sometimes nurses will even put a sign on the board that says, before next dressing change, please administer pain medication. Right? So debridement, sometimes we want to use wet to dry dressing changes to facilitate debridement. Right? All right, so healing process. So this is another way that we classify wounds. Would be primary, secondary, or tertiary intention. So with primary intention, the wound has little tissue loss. There's not a whole lot of tissue involvement. Little tissue loss. The skin edges are approximated. That means that they're side by side, right? The degree of reaction, it has localized redness and edema around the incision. So it's a normal finding to have a little bit of swelling, tenderness, a little bit of redness around the incisional site. Secondary intention, the wound edges are separated, so they're farther apart. It needs to heal with granulation tissue from the bottom of the wound up. And if that doesn't occur, what will happen is they'll have a dead space of just a pocket of air there. So we want it to fill up from the bottom up with granulation tissue. They have large open wounds, and so they'll drain more fluid, and they may have chronic inflammation. With secondary intention, they are filled with fragile epithelial and granulation tissue in the wound bed. So it's easily, if it's disturbed, it will bleed very easily, and it will heal. It takes a little longer for that to heal. Tertiary intention, the wound edges are separated. It heals from granulation tissue from the bottom, but at a very slow rate because of an infection. That's a secondary to infection. So when you see a tertiary intention, that means it might have been like a primary wound or primary intention surgical incision that has become infected. And so now they've left it open, and we're doing dressing changes to try to get rid of the infection. And we'll close the wound at a later date. Sometimes tertiary intention wounds require skin grafts. Not always, but sometimes they do. So with that, with the A, B, and C, and I know it's probably difficult for you to see. I think you have this little slide in your PowerPoint. So on A, that is primary, so they have a fine scar, not as much tissue loss. B, they may have a little larger scar because they have a larger area that's been compromised. And then C, their wound is contaminated. So it's going to take a little longer to heal, and they may have a larger scar as well. Out of these three, which one has the greatest risk for infection? Which one do you think would have the greatest risk for infection? If you think it's A, raise your hand. Okay, if you think it's B, raise your hand. If you think it's C, raise your hand. It's actually C. All right, so here's an example of a wound that's healing by primary intention. The edges are approximated, they're closed together, and it's held together with staples.
How can it be, isn't it already infected if it's contaminated or not?
It is infected, and we're working on reducing that infection, but there's still a greater risk of reintroduction of organisms because it's open.
Okay.
And so that's where hand hygiene and best practices is regarding to sterile technique sits on the shoulders of the nurse so that we don't reintroduce any other infection. Yes, ma'am.
You said that primary intention is an expected finding of wound.
So with primary incision, well, let's go here. Okay, so this is a primary intention or wound healing. So it's expected that there be edema alongside the edges. Along the edges, edema is an expected finding. Tenderness and a little pinkness is also an expected finding. As the nurse, as I continue to assess this wound, say I have this patient's first post-op day 0, and I continue with their care to post-op day 2. Should those signs and symptoms worsen or get better? Get better. So if I have a patient with a primary intention or a surgical incision, and the edema is getting worse, now it's not pink, it's red, that's a problem, right? But in the initial stages, that's an expected finding. All right, so this is an example of secondary intention. So with secondary wound closure, this is healing of a wound where the edges cannot be approximated. They can't come together easily. This requires granulation tissue, a matrix to fill in that area, and for the wound to heal. This type of healing takes more time, obviously, and it creates more scar tissue. And the majority of non-surgical wounds heal this way, secondary intention. Non-surgical wounds. All right, and then the last example I have is the tertiary intention. This is also known as delayed primary closure because it's a combination of both primary intention and secondary intention. This method is left. We do it this way because a wound has become infected. So if they sutured something up, the wound up, and then 3-4 days later we notice, okay, there's an infection in that wound. Well, we can't let the infection just stay in and fester. We have to open that back up and clean that wound out, and then they're going to leave it open for a little while. The doctor will, or the surgeon will determine the time frame so that we can assess that wound a little better. And then the plan is usually to close that back up at a later date. We just want to make sure that there are no lasting infection in that wound. Examples of wounds that are closed this way are usually traumatic injuries, so dog bites, traumatic amputations, or lacerations that involve foreign objects. Sometimes your gunshot wound victims, they'll have to be healed this way. This is not the first thing that we choose to do. This is tertiary occurs when there's been an infection in that primary closure. Okay? So some factors that affect wound healing. Some of these we can't modify and some of them we can. Nutrition, obesity, if there's impaired blood supply, the use of drugs, prescription drugs and street drugs, wound stress, diabetes, and aging. Those are all factors that affect our body's ability to heal our wounds. Nutrition is very important, and oftentimes nutrition is just overlooked, but it's very important in the wound healing process. For our wounds to heal properly, we have to have nutrients. Our body's ability to heal is depending on having the right nutritional components. So vitamin C, we know that assists in formation of collagen fibers and capillary development. That is so important. Protein, we need amino acids. Those are the building blocks of life, right? Amino acids for tissue repair. Carbs, we need some carbs. That's our primary energy source, so that protein is used for tissue repair. Zinc assists in epithelialization of that new growth. And then calories. To support the increased stress of healing, our body requires a higher caloric demand. Do you guys not have this slide? Okay. Well, somebody send me, well, I'll remember. I'll send this to you. I'll post this one. So, with nutrition, obesity, we know that with our patients who are obese, there's difficulty in approximating wound edges with adipose tissue. You don't have this one either? Come on, what's going on? All right. So we know with obesity, there's difficulty in approximating that adipose tissue. The wound edges. It's hard to approximate. Depending on where the location of the wound is, with our obese patients, they may support bacterial growth. Oftentimes with obese patients, especially with abdominal wounds, they're very difficult to keep clean and dry because of the location and because of the pressure that's being exerted. Poor blood supply of adipose tissue diminishes oxygen and nutrients that are required or essential for healing. Okay.
Everything you're saying, we're not.
Oh, where's your little? Let me see.
Here.
Oh, that's the wrong one. I won't take the time. I'll look at your slides again. Whatever you don't have, I'll send you today. Okay? All right. So impaired blood supply, another factor affecting wound healing. With impaired blood supply, of course, there's going to be decreased amount of nutrients that are available to the wound. There's going to be impaired removal of exudates or fluids away from the wound. And it's going to inhibit the inflammatory response. Vascular issues that also speak with impaired blood supply, if our patients have any vascular disease, so peripheral vascular disease, or if they have comorbidities that have compromised their circulatory system, such as diabetes that plays havoc on that, or uncontrolled hypertension. That's a factor that will impair wound healing. Also, if they're on any medications, routine maintenance meds that cause vasoconstriction, that's going to impair blood supply. What other habit do we see all the time, and you hear about it pretty much in every concept we have addressed with you, that is a modifiable factor for patients that we see that they do that impairs wound healing? Smoking. Drugs that affect wound healing. So your corticosteroids. You know, steroids they're anti-inflammatories, and they can prohibit that inflammatory response from occurring, and we know we need that inflammatory response to help activate that wound cascade, wound healing cascade. Antibiotics and then also chemotherapeutic agents can affect wound healing. We're going to talk a little bit more about corticosteroids, anti-inflammatories, antibiotics, and chemotherapy. So with our corticosteroids, again, they're going to inhibit the inflammatory response. They impair the phagocytosis by the white blood cells. They slow and impair wound healing. They suppress collagen synthesis. So it's going to slow everything down. They inhibit the fibroblast proliferation. They depress formation of granulation tissue, and they inhibit wound contraction. So corticosteroids, they just slow everything down on that healing cascade. You know, we've talked about, you've heard about opioids and how it slows everything down in the body. Same thing happens with corticosteroids with wound repair, wound healing. It just slows everything down. It makes the body fight harder than it has to. Another factor that affects wound healing is the use of anti-inflammatory drugs. Again, we want that inflammatory response to occur, especially with the acute wound, because we know that's what's going to initiate all those clotting factors. That's what's going to initiate that wound healing cascade. So we need that component. Antibiotics If our patient has been using antibiotics for a long time, they can they risk getting a super infection, such as MRSA or C. diff, right? And antibiotic resistance. Chemotherapeutic drugs, most of them are designed to inhibit cellular metabolism, rapid cell division, and angiogenesis. So that disrupts the pathways that are critical for wound repair. So chemotherapeutic drugs are going to inhibit wound healing. It also slows the growth of those growing cells and then depresses that bone marrow function, resulting in leukocytes. So chemotherapeutic drugs will definitely affect the body's ability to repair itself, healing. Another factor that can affect wound healing is the wound stress. So depending on where the wound is on the patient, there may be additional pressure there, right? So that's going to disrupt the collagen base. And then other causes that can increase stress on a wound. Anything that you can think of? What would cause stress on a wound? Let's say I have an abdominal wound. What would cause stress on that?
For people that I have when they stretch the sweat, pulls the incident,
Okay, so coughing. So positioning, coughing. What about vomiting? Abdominal distension. The dehydration actually increases stress on a wound, and so does the presence of infection. So those would all be factors that would affect wound healing. Diabetes. We know with diabetes, you had a whole big lecture on diabetes. Does it not affect everybody's system? Yes. With wound healing, because we have increased collagen synthesis, our diabetic patients, their wounds do not heal as fast. Another problem that our diabetic patients face is if they cannot control their blood glucose levels, if they have unstable blood glucose, that's also going to go against them as far as wound repair goes and wound healing. It predisposes them to an increased risk for infection. There's not as many nutrients, not as much oxygen being delivered to the wound because of the vascular damage that has occurred in most diabetic patients. If you've taken care of a diabetic patient who has had peripheral neuropathy, raise your hand. And they have nerve pain in their legs. They probably were on gabapentin or Neurontin. It's pretty common. Those patients are going to have a slower healing time because of the effects of diabetes on their systems. Another factor that affects all phases of wound healing would be aging. So just take a minute and think about why would aging affect wound healing? Do things speed up as we age? Do things slow down as we age? It slows down, right? So they probably have impaired circulation to that wound, so they're not getting the blood supply and the nutrients. What about their liver functions? It's probably slowed down, so they're altered. They're not synthesizing those clotting factors as rapidly. Their inflammatory response is probably slower. They don't have as many antibodies circulating around in their immune system or lymphocytes. And then a lot of older adults, not every, but a lot of older adults, their nutritional status can be compromised. They may have poor nutrition. So those are all factors that can affect or impede wound healing. So, common complication of wound healing. Hemorrhage is a pretty important one. It is a common complication of wounds. It can be caused by either a slip surgical suture or a dislodged incisional clot. It might present as a hematoma. They might have some distension or swelling at the surgical site. And again, as you're assessing your patients, especially with surgical incisions, they should be progressing to they should be doing better as the days go forward. They shouldn't be having more pain, more swelling, more drainage. That's an indicator that something is wrong. They could have erosion of blood vessels by a foreign object, so if they have like a JP drain inserted or some type of drain inserted that it could erode their blood vessels, they may even develop hypovolemic shock, which that's pretty high degree of reaction, but it could happen. So just know that hemorrhage is a common complication. Infection is another common complication, and with delayed wound closure, it is generally accepted if the patient has pus draining from it, it is infected. So it's generally accepted that the wound is infected if pus is draining from the wound. Symptoms that you might see would be fever, increased drainage, swelling, redness, increase in tenderness and pain to touch, right? And again, that would be an indicator of infection. This may not develop until the 4th or 5th post-operative day. Some of our patients go home post-op day 2. So this would be very important discharge information that we would need to share with our patients before the 4th or 5th day. So again, your symptoms: fever, increased drainage, swelling, redness, increased tenderness or pain. So this is an example of an infection and a delayed wound closure. So it can also be affected, again, like we spoke about, with obesity and the location of the wound because of the increased wound stress or pressure on that wound. So antibiotic therapy for infected wounds. Cephalosporins are commonly prescribed. They're a broad spectrum bactericidal antibiotic. So before we will hang an antibiotic, we want a culture and sensitivity. The CNS means culture and sensitivity. Before initiating treatment, before I hang that first antibiotic, why is it important to have a culture and sensitivity before I go ahead and give them their antibiotic? Okay, so she said the antibiotic can alter the culture. What was your response?
Similar.
Okay.
Change the results.
Okay. We're looking for the right med to treat the bacteria. If I am giving them a medication, an antibiotic, that is not going to get rid of whatever the pathogen is, then I'm just setting them up for a super infection, right? So I want to make sure that the doctor has ordered the right medication to treat this patient. So, yes?
Don't they give them first a broad spectrum antibiotic?
This is a broad spectrum. Yeah. So, but before I even hang it though, I want to make sure that what I'm hanging is going to get rid of the microorganism that I'm trying to get rid of, right? Because I don't want my patient to get a super infection. If we don't do a culture and sensitivity before the initial treatment, we may be just wasting meds and then prolonging intervention that would actually help our patient. All right. They usually will have medication, cephalosporin, administered around the clock for 10 to 14 days. We want them to report signs of a yeast infection. We want them to report signs of furry tongue or perineal itching. We want them to tell us if they have urticaria or hives, pruritus, or itching. If they develop the furry tongue or the perineal itching, it's usually because the body's normal flora has been disrupted, and so yeast is now coming on board. They may need a probiotic when they're on a medication, IV antibiotic, for this many days. Probiotics like Culturelle, they add that good, healthy bacteria back to your digestive system. So we're going to monitor for side effects of rash, urticaria, and pruritus. And then cephalosporins are excreted in the urine, so we have to be careful with our patients that have renal impairments. So a complication of wound healing would be dehiscence. That is when there is a partial or total separation of wound layers. Early dehiscence may be due to technical factors. or stresses on the wound, such as vomiting, abdominal distension, excessive coughing, infection, and dehydration. Later dehiscence may be due to increased stress on the wound, and we see that most commonly 3 to 11 days post-operatively. So usually by post-op day 4 or 5, the patient can be home. They may not even be in the hospital. So this is something that we would definitely need to include on our patient teaching and discharge instruction. So early dehiscence due to technical factors. And I said, what does that mean? So technical factors might be the sutures weren't in place, they didn't have as many sutures as they really needed, or staples came loose too early, or the surgical glue didn't stick, right? So that would be a technical factor from early dehiscence. And here's an example of dehiscence. So you can see where the edges are no longer approximated. And this is an abdomen. There's their umbilica. I'm going to get my pointer right there. So the edges are no longer approximated. You can kind of see where they stretch. Looks like they stretched some stitches there. Another complication of wound healing that is considered a medical emergency is evisceration. That occurs when the visceral organs protrude from the wound after total separation of wound layers. So dehiscence has occurred. The next step is evisceration, right? So the patient might report a giving sensation at the incisional site. They may have a sensation of wetness because fluid is now draining from the site. Or you might see that they're dressing, which you maybe monitored in the morning, assessed in the morning, and it had like maybe a nickel-sized amount of drainage now is saturated side to side. That would be an indicator. And then the patient may have pain. The dressing may not have bright red, frank blood. It may have serosanguinous blood or like a serous color, white, clear to light pink. So it may have that. So here's an example of evisceration. I have seen this. I actually had a clinical group with a patient that had an abdominal wound, and he had a lot of things going on, and he had evisceration. So he was in the bed, and you could see his bowels just pulsating. So the peristalsis, you could see that. It is a medical emergency, and we're going to talk about what in the world would you do as the nurse. You would not go on break. You guys are a tough crowd. Okay, so you would want to soak sterile towels or dressing in normal saline, and you would want to lay those over those organs to maintain moisture. So that's going to be very important that the organs don't dry out, that we maintain that moist environment. We're using sterile supplies so that we don't introduce any pathogens to the patient. We're going to ask the patient to remain calm as possible, and we're going to assure them that we're right here with you, we're not leaving you, we're right here with you, and we're going to notify the surgeon, who will probably, well, they will, take you back to surgery to fix this. But I'm going to be right here with you, and you need to be as calm as possible. So, you would call the physician, yes, but that is not the first thing that you're going to do at the bedside if your patient has this problem. What would be the first thing you do? Do what?
Treat for shock.
Treat for shock?
Like prevent shock.
Be sure that I'm sure the patient remain calm. Like,
So the first thing I'm going to do, my patient's in the bed, laid back, eviscerated. I'm going to soak those sterile supplies with normal saline. I'm going to put that on my patient and encourage them to remain calm. And I'm going to stay with my patient while I hit the call light and say, I need the physician's stat. I probably would call a code to get them there, right? But I want to make sure that my patient's organs stay moistened, right? Make sense? All right. Timekeeper, where are we at? 1 minute? All right. Go ahead. Before we get into fistulas, go ahead and take your 10-minute break. It's 9:49, so I'll see you at 9:50.
Who's next? Huh? Yeah. She had to read that. Yeah. She's fine. But this is no, it's a parfait, you know parfait, right? It's all vegan pastry, like the most delicious coffee and oatmeal. Yeah, vegan like ice cream. When we release, I don't love it. I like the other ones, right? I'm not like super in love with any of them, you know.
True that.
What number? 'Cause I'm gonna listen to it. If I do, let me put a star next to it.